Dear students, in this module we will cover Millennium Development Goals and health achievements. Specifically, we will be learning about the Millennium Development Goals in general and Millennium Development Goals specifically related to health, the kind of relationship between Millennium Development Goals and health. Then we will talk about MDG 2, which has targets for nutrition, and nutrition is directly or indirectly related to health. Then we will also cover MDG 4 in terms of child mortality, the targets, the achievements and the progress made so far. Then we will cover MDG 5 in terms of maternal health, the target, the progress and the achievements. In terms of MDG 6, we will talk about malaria and TB, the situation, the progress and the achievements. Let us talk about the Millennium Declaration. The UN Millennium Development Goals are 8 goals that all the 191 UN member states agreed to try to achieve by 2015. This UN Millennium Declaration was signed in September 2000 and it commits the world leaders to combat poverty, hunger, disease, illiteracy, environmental degradation and discrimination against women. The MDGs are derived from this declaration and all the MDGs have specific targets and indicators. Let us look at the Millennium Development Goals. There were 8 goals. These pertain to eradication of extreme poverty and hunger, achieving universal primary education and promoting gender equality and empowering the women, reduction in child mortality, improving maternal health, combating HIV, AIDS, malaria and other diseases and ensuring environmental sustainability and to develop a global partnership for development. When we talk about the association between MDGs and health, MDGs are interdependent and all the MDGs have influence on health status and health also influences all the MDGs. For example, better health enables the children to learn and adults to earn. Gender equity is also essential to achieve better health. Reduction in poverty, hunger and environmental degradation have positive impact on health. They also depend on health. Let us look at goal 2. Goal 2 has targets related to child nutrition. In terms of proportion of children under age 5 who are underweight, and it has been cut almost in half between 1990 and 2015, but over 90 million children under age 5 worldwide remain underweight. In terms of nutrition goals and targets, we have to understand that underweight children are at greater risk of dying from common infections, and underweight and malnutrition also increases frequency and severity of such infections and contributes to delayed recovery. Poor nutrition, particularly in the first 1000 days of life, is found to be associated with impaired cognitive ability and reduction in school and work performance. If we look at the nutrition situation across the regions, 2 regions account for nearly 90% of all underweight children in 2015. Half of them live in Southern Asia and 1/3 of them live in Sub-Saharan Africa. East Asia and Latin America and the Caribbean were able to meet the targets. The projections indicated that some of the countries, particularly from Central Asia, Northern Africa, Southeast Asia and Western Asia, were able to meet the target. In the Asia and Pacific region, South Asia had highest underweight prevalence, with 1 in 3 children still affected in 2015. This region experienced largest absolute decrease since 1990. In the sub-Saharan Africa, underweight rate declined by 1/3 since 1990, but with the growth in the population, the number of underweight children has also gone up. Stunting is another indicator of nutrition status of the children. It is defined as inadequate height for age, and it is considered as a better measure than the underweight, and it is also more common than underweight, and it affects approximately 1 in 4 children under 5 or 161 million children worldwide in 2013. Number of stunted children has declined in all the regions except sub-Saharan Africa, where the numbers increased by about 1/3 during 1990 and 2013. Children from the poorest 20% of the population are more than twice as likely to be stunted compared to the children from wealthiest quintile. Goal 4 talks about reduction in child mortality. At the global level, under 5 mortality rate declined by more than half, from 90 deaths per 1000 live births to 43 deaths per 1000 live births between 1990 and 2015. Number of deaths of children under 5 declined from 12.7 million to 6 million during 1990 and 2015 at global level. Since the early 1990s, the rate of reduction of under 5 mortality has more than tripled, but in sub-Saharan Africa, annual rate of reduction of under 5 mortality was over 5 times faster during 2005-2013 compared to the reduction during 1990 and 1995. Measles vaccination significantly helped in preventing nearly 15.6 million deaths during 2000 and 2013. Number of globally reported measles causes, the number of cases of measles reported declined by 67%. Across the world, 84% children received at least one dose of measles to contain the measles epidemic. Across the globe, 84% children received at least one dose of measles vaccine. And goal 4 also talks about reduction in child mortality besides under 5 mortality. There were improvements in most of the regions in reducing the child mortality, but the trends indicate that the change was not sufficient to meet the target, and at the current rates of decline, it may take more number of years to reach the global target. About 16,000 children under 5 continue to die every day in 2015, and then most of them would perish from preventable causes such as pneumonia, diarrhea and malaria. Sub-Saharan Africa has the world's highest child mortality rate. In spite of that, absolute decline in child mortality has been largest over the past 2 decades in this region. Under 5 mortality rate has declined, but the sub-Saharan African region faces an urgent need to accelerate the progress, because the sub-Saharan Africa carries about half of the burden of world's under 5 deaths, and it is also the only region where both number of live births as well as under 5 population are expected to increase substantially in the next few decades. An additional 1 million children will die in the first week, and around 2.8 million will die during their first 28 days of life. that is the neonatal period. Between 1990 and 2015, worldwide neonatal mortality rate has fallen from 32 deaths to 19 deaths per 1000 live births. Decline in neonatal mortality has been slower than decline in mortality for children aged 1 to 59 months. The neonatal deaths now represent a larger share of the total under 5 deaths. Every region of the world is experiencing an increase in proportion of under 5 deaths that occur during the neonatal period. Majority of the neonatal deaths worldwide are caused by preterm birth complications, complications during labor and delivery, and sepsis. In sub-Saharan Africa and South Asia, many of the neonatal deaths were due to preventable infectious diseases. Though there is a link between country's level of income and its child mortality, the evidence from many low income countries such as Bangladesh, Cambodia, Ethiopia, Uganda, Tanzania, etc. indicates that low income need not be a constraint to save the children's lives. Now let us move to goal 5, improve in maternal health. Since 1990, maternal mortality ratio has declined by 45% worldwide, and most of this reduction happened since 2000. In South Asia, MMR declined by 64%, and sub-Saharan Africa recorded a decline of about 49% during 1990 and 2013. More than 71% of the births were assisted by skilled health personnel globally in 2014. This is an increase from 59% recorded in 1990. In North Africa, proportion of pregnant women who received 4 or more antenatal visits also increased from 50% to 89%. The contraceptive prevalence among women of 15 to 49 years also increased worldwide. In developing regions, only 56% of the births in rural areas were attended by skilled health personnel compared to the figure of 87% in urban areas. Only half of the pregnant women in developing regions receive recommended minimum of 4 antenatal care visits, but only 51% of the countries have data on maternal cause of death. Maternal survival has improved significantly since adoption of the MDGs. We have seen decline in MMR and decline in number of maternal deaths, and many developing countries have made considerable and significant progress towards improving maternal health, and some of these regions include countries with highest MMR as well. In South Asia, MMR declined substantially. Same is the story in case of sub-Saharan Africa. Globally, there were an estimated 289,000 maternal deaths in 2013. That means about 800 women dying each day, and these deaths were concentrated in sub-Saharan Africa and South Asia, and most of these deaths are preventable. This is the challenge before us, to bring down the number of maternal deaths across the regions and countries of the world. Progress in raising the proportion of births delivered with still attendance has been modest during the course of MDG time frame. Perhaps universal access to care is still an issue to be addressed. Globally, proportion of deliveries attended by skilled health personnel increased to 71% by 2014. That means more than 1 in 4 babies and their mothers were left without access to crucial medical care during the childbirth, and this coverage ranges from universal in the East Asian countries and nearly universal in Central Asia to very low levels of coverage in sub-Saharan Africa and South Asia. As on 2014, only 52% of the pregnant women in developing regions received the recommended number of antenatal care visits during the pregnancy, and progress in this direction has been very slow in the last 2.5 decades. In South Asia, just 36% of the pregnant women only received 4 or more antenatal visits during 2014. Now let us move to goal sheets that talks about HIV, AIDS, malaria and other diseases. We will focus on malaria and tuberculosis in this module. Between 2000 and 2015, global malaria incidence has declined by an estimated 37%. Global malaria mortality also declined by about 58%. As a result of this, the global MDG malaria target had been achieved. Increased worldwide attention and substantial expansion of anti-malaria efforts helped in averting over 6.2 million malaria deaths during this time period. The estimates indicate a reduction of 69% in malaria mortality in under 5 age group, and this helped immensely in improving the child survival rates, and it also contributed directly to MDG 4 that involved reduction in child mortality by 2/3. As of 2015, 98 malaria epidemic countries have revised incidence. As of 2015, 98 malaria epidemic countries have reversed incidence of malaria nationally compared to 2000. But still, malaria continues to pose a major public health challenge with an estimated 214 million cases and 472,000 deaths globally during 2015. Malaria is still endemic in 97 countries and territories around the world, with about 3.3 billion people being at risk of infection, and malaria accounts for a large proportion of health spending in low income countries. 80% of the global malaria deaths occur in 17 countries only, mostly from the African region. Massive gains over the past 15 years due to largely a tenfold increase in international financing for malaria since 2000. It, together with strengthened political commitment and availability of new and more effective tools, helped in improving the situation in case of malaria. Past 15 years have shown how effective a public health intervention can be in reducing malaria cases and saving lives. Now let us move to tuberculosis. TB incidence rate has been falling in all the regions since 2000, and the decline was about 1.5% per year on an average. This corresponds to an estimated 9 million new cases in 2013. Rate of decline, however, has been slow due to lack of effective strategies such as post-exposure vaccine or treatment for latent TB infections. Globally, TB mortality rate also declined by 45% between 1990 and 2013. In 2013, there were 1.1 million deaths from TB among HIV negative people, and an additional estimated 360,000 deaths among HIV positive people. 11 million people were living with TB, representing about 41% decline in prevalence since 1990. Of these, 13% were HIV positive. The projections indicate a rate of decline in both mortality and prevalence rate is close to reaching the global Stop TB partnership target of 50% reduction by 2015 compared with 1990. Reductions in disease burden follow 20 years of intensive efforts to implement DOT strategy and its successor Stop TB strategy. Between 2000 and 2013, an estimated 37 million lives were saved by TB prevention, diagnosis and treatment interventions. Globally, number of people receiving TB treatment increased from 2.9 million to 5.8 million, with treatment success improving each year. Among patients newly diagnosed in 2012, 86% were successfully treated globally. Having observed the trends in the health related indicators from the MDG point of view, let us now discuss about some of the results with the help of some charts. To start with, let us have a look at figure 1. This chart gives us the proportion of children under age 5 who are moderately or severely underweight at two different time points, 1990 and 2015, the time reference period considered for the Millennium Declaration MDG goals achievement. It also gives us the differentials by region. We can see there is an increase in trend in reduction of underweight children from 1990 to 2015. Across the regions, there has been decline in the number of or proportion of children below 5 who are moderately or severely underweight during the reference period of 1990 and 2015. In case of South Asia, the decline was from 50% to 28%. In case of Sub-Saharan Africa, the decline was from 29 to 20. Across the world, the decline was from 25% to 14%. Figure 2 gives the under 5 mortality rate for 1990 and 2015. These are the deaths per 1000 live births during the first 5 years of life, and then the differentials are clearly visible here. In case of Sub-Saharan Africa, there is a decline of about 52% from 1990 to 2015. In Oceania, the decline was 31%. The South Asia recorded a decline of 60%. Southeast Asia recorded decline of 62%, while West Asia recorded decline of 65%. The developed regions recorded decline of 61%. Developing regions recorded lower decline of 53%. Across the world, the decline was of about 53%. Let us look at figure 3 that gives the number of deaths by day in the first 28 days of life in 2013 in terms of thousands. It starts from day of birth up to day 27. 1 million deaths were estimated to be taking place on the first day of life. That means 36% of the neonatal deaths, and 2 million deaths were occurring in the first week of the birth, accounting for 73% of the neonatal deaths. The chart is very disturbing because more and more newborns were dying on the first day itself. This is a major concern. The reduction in child mortality, infant mortality and under 5 mortality across the regions has been significant and has been tremendous. However, the further reductions in infant mortality or child mortality or under 5 mortality largely depend on our ability to succeed in controlling the number of deaths that were happening during the first day or first week of the life. Let us look at figure 4 that gives the ratio of under 5 mortality rate for children by residence, wealth quintile and mother's education. Then let us move to figure 5. It gives the annual rate of reduction in the under 5 mortality rate in developing regions in terms of percentages between 1990 and 2013. Many of the developing regions also have recorded considerable decline in terms of percentage of under 5 mortality rate between the reference period of 1990 and 2013. Now, let us move to figure 6. It gives the estimated number of child deaths due to measles and proportion of children in the appropriate age group who received at least one dose of measles vaccine between 1990 and 2013 for sub-Saharan Africa, South Asia and other regions. This indicates the relationship between measles vaccine coverage and the risk of child death. Figure 7 gives the maternal mortality ratio at 3 different time points 1990, 2000 and 2013. The maternal mortality ratio is defined as maternal deaths per 100,000 live births among women aged 15 to 49. It also indicates the percentage decline between different time points in the maternal mortality ratio. Figure 8 gives the proportion of deliveries attended by skilled health personnel in terms of percentages at 3 different time points 1990, 2000 and 2014. In all the regions there has been an increase in proportion of deliveries attended by skilled health personnel. Though in some of the regions the proportions are still not universal, there is a scope for further improvement of the proportion of deliveries attended by skilled health personnel. Figure 9 gives the proportion of deliveries attended by skilled health personnel in rural and urban areas and the changes between 2010 and 2014. The figures are indicating significant rural urban differentials and the issues relating to inequity between rural women and urban women. The rural women seem to be deprived of the facilities from the delivery care point of view. Figure 10 gives the proportion of children under age 5 sleeping under insecticide treated mosquito nets for a few countries in sub-Saharan Africa. At 2 different time points 2001 and 2013. In almost all the countries there has been significant improvement in coverage of children with insecticide treated mosquito nets. In some of the countries the change has been very significant, whereas in some countries the change has not been so significant, but however the trend indicates overall improvement in coverage of children under 5 with sleeping insecticide treated mosquito nets. Figure 11 gives the TB incidence, mortality and prevalence rates, estimated numbers per 100,000 population. The trends are showing a declining pattern over a period of time. Figure 12 gives the TB treatment success rate for developed and developing regions. For the developed regions, the success rates have improved considerably and they have surpassed 85% mark, whereas in case of the developed regions the success rate has increased and improved, but still there is scope for further improvement. So, in this module we discussed about the association between MDG goals and targets and health. We understood that the MDGs are interdependent and MDGs also influence health and health also influences all the MDGs, and we looked at the kind of improvements the countries were able to make in terms of MDG goal with specific reference to child nutrition, considerable improvement in reduction of underweight and reduction of stunting across the regions, and we also looked at the prevailing stunting and undernutrition levels in various regions. Then we discussed about the goal 4, which pertains to reduction of child mortality, and then we have seen decline in trends in under 5 mortality as well as child mortality. We also have seen improvement in coverage of children with measles vaccination, which contributed to significant decline in global burden of disease from measles and also decline in deaths due to measles. In spite of these improvements across the regions, the message is that much more sincere and serious efforts are required to fasten the pace of decline in child mortality and infant mortality besides under 5 mortality. As regards the goal 5 relating to improving maternal health, maternal mortality ratio has declined substantially, and then delivery assistance by skilled health professional has improved substantially across the regions. We also have seen substantial improvement in case of antenatal coverage services utilization by the women during their pregnancy. We have seen the regional differentials in terms of maternal mortality decline, particularly the maternal deaths that are happening in South Africa and South Asia were major concerns, and the maternal deaths, as we have seen, are preventable. Efforts are required to further reduce the maternal death rate, and universal access to care and services must be ensured to all the women across the regions. Then we also discussed about the improvement in case of malaria and tuberculosis. The global malaria mortality rate decline, and then the global malaria incidence decline have been significant achievements in the light of efforts done as part of the Millennium Declaration achievement, and these also contributed directly to achieve the MDG 4 that relates to child mortality. As regards tuberculosis, there has been substantial improvement in TB successful treatment, and then TB incidence rate has also experienced decline across the regions, but the rate of decline is relatively slow and needs to be fastened up. We also have seen the improvements that happened in TB treatment, diagnosis and malaria treatment facilities. We also have seen improvement in provision of bed nets for the children to be covered while they were sleeping, so that they get protected from malaria. So, all these efforts as part of the MDG framework have helped us in achieving the expected results in most of the countries, but in some countries still efforts are required to further improve the situation in terms of the maternal and child health. This would be the agenda for the sustainable development goals for 2015 to 2030 that would be carried out by the respective governments across the regions of the world. Thank you so much.